Doctors, in this video, let us discuss about the airways and lung parenchyma, the physiological concepts behind the normal functions of airways and lung parenchyma, that is entry of air into the lungs and how air gets out of the lungs. So, breathing, inspiration and expiration, all the physiological concepts behind the air entry and air exit. Deep, and it will be quite conceptual, so I want you to pay very close attention. Okay, if you got any other distracting things around you, please make sure you switch off those things and let us try to focus very deep on this concept, because these are all very important, as well these are all very time consuming to understand also. So fine people, let us move on here. Now to begin with, we do have airways, and that is how the whole lung is being arranged, doctors. We do have proximal airways, we do have trachea. Trachea divides into principal bronchi. Principal bronchi also called as main stem bronchi. Now this principal or main stem bronchi divides into, they divide into and another structure called as segmental bronchi. Segmental bronchi in turn divides into lobar bronchi. Right, doctors? Lobar bronchi in turn divides into bronchioles. So we have primary bronchiole, we have secondary bronchiole, which divides into terminal bronchiole. So all these structures are primary, secondary and tertiary bronchioles. Okay, now the importance in using different colors for different segments are like here, doctors, trachea and main stem bronchi, these two are called as, these two structures, trachea and main stem bronchi or principal bronchi, they are large airways. Large airways, while segmental bronchi and lobar bronchi, segmental and lobar bronchi are medium sized airways. Medium sized bronchi, to be very precise, medium sized bronchi, whereas primary, secondary, tertiary bronchioles are medium sized airways. Again they are medium sized, but they are medium sized bronchioles. Okay, now if you look at the anatomy, my dear friends, trachea and bronchi, they will be containing cartilages on their walls. Okay, trachea do have cartilaginous rings, whereas bronchi do have cartilaginous ring, and certain bronchi they don't have ring, they do have cartilaginous plates. Okay, so trachea and bronchi do have cartilage on their wall. They are either cartilaginous rings seen in trachea or cartilaginous plates seen in bronchi. Okay, so we do have cartilaginous rings and cartilaginous plates, doctors. Now the importance of presence of cartilage in trachea and bronchi is this. Now you might have done your dissection, my dear friends. In your dissection you could have picked up an artery, you could have picked up a vein. By simply looking at an vessel, you can either able to say whether this is an artery or vein, isn't it? How do you differentiate between an artery and a vein in a cadaver? An artery will always remain open and there is a good amount of lumen visible in an artery. When it comes to a vein, you cannot see a vein in a cadaver with a inflated lumen. Ignore superior and inferior vena cava. You take up normal veins, brachial vein, cephalic vein. When you take up these normal veins, after embalming is done, you cannot able to see the vein with its normal lumen and caliber. The vein will always be shut flat like this. Okay, so arteries do have an intact lumen. Arteries do have an intact lumen, but veins do not show their lumen because their walls are collapsed. The reason of arteries which with an exposed lumen and veins with a collapsed wall is this. Arteries are thick structure, muscular structure, their walls are always open irrespective of presence or absence of blood. It doesn't matter when either blood is inside an artery or there is no blood inside an artery, arterial walls are always remaining open because their walls are very thick and very muscular, okay, very elastic also. When it comes to veins, their walls don't have enough smooth muscles, their walls don't have enough elastic tissue. Because of absence of smooth muscles and elastic tissue, their walls cannot able to stay open, they get flat. So as and when blood flows into a vein, only then the vein looks inflated. When there is no blood flow into a vein, the vein stays flat. Now this is one example that will be applied to airways of lungs. In another way, if you want to understand this in a simpler way, you know how a PVC pipe is there. You might have had pipes in your households, right? And these pipes are very cylindrical. It doesn't matter, you open the tap or not, it doesn't matter. Though there is water inside the pipe or not, it doesn't matter. The pipe always maintain its circular tubular structure. The pipe will always be remaining like this. It doesn't matter, either there can be water inside or not, it doesn't matter, the pipe, okay, PVC pipe is going to remain cylindrical like this. On the contrary, if you happen to have a look at a firefighting hose, okay, now whenever firefighting hose are used, in your medical colleges or in your institutions, in your schools or wherever, when there is a mass gathering, it is mandatory that you need to have a fire safety equipments and all. So if you look at the firefighting hoses, they would have rolled the firefighting hoses in a tape like fashion and they will be storing it. So only when water is present inside the pipe looks cylindrical and inflated, okay. When there is no water inside, the pipe will not remain cylindrical, it becomes flat, okay. So as and when water enters, the pipe looks cylindrical, when there is no water, pipe becomes flat. So this is the nature of a firefighting pipe, doctors, firefighting hose. Now if you consider these two structures, the reason for something maintaining its patency is the strong walls, and the reason for a structure not able to maintain its patency is a very weak wall. Now remember, it is the very same condition with the airways of lungs. Since trachea and bronchi do have cartilage on their walls, okay, trachea and bronchi are going to stay open, in spite of presence or absence of air in it, okay. So either there can be air in or there is no air in spite of presence or absence of air, trachea and bronchi are going to stay open, doctors, which is why if you take a look at a butcher shop or if you take a look at your anatomy dissection hall, the museums, okay, lung specimen will be kept in the formalin jars, isn't it, my dear friends? If you could able to remember your you seeing that museum specimen lung jar, you can able to appreciate that the lungs will be present in the jar with the trachea well inflated and trachea remaining in its normal luminal shape, okay. Trachea and bronchi remain absolutely fine and normal in spite of presence or absence of air in it, doctors, okay, fine. When it comes to these bronchioles, okay, now let us take bronchioles and see bronchioles in a deeper way, okay. So we just told that there is going to be a primary bronchiole, and primary bronchiole is going to split into secondary bronchiole, which is going to in turn split into tertiary bronchiole. This tertiary bronchiole is going to divide into another set of tube called as alveolar duct. Alveolar duct in turn leads to a dilated sac called as alveolus. Okay, this in turn leads to dilated sac called as alveolus or alveolar sac, which consists of multiple alveolus. Right. In certain conditions, the tertiary bronchiole, okay, this is secondary, primary, secondary and tertiary. Tertiary bronchiole in turn divides into another structure called as respiratory bronchiole. Okay, certain parenchymas do have another intervening structure called as respiratory bronchiole, and respiratory bronchiole in turn divides into alveolar duct, and this alveolar duct ends into alveolar sac, which consists of lot of alveolus. Okay. So, certain structures will have respiratory bronchiole between tertiary and alveolar duct, doctors. Now, the importance of respiratory bronchiole here is there are few alveolus, although not completely, there are few alveolus connected to respiratory bronchiole straight away. The walls of respiratory bronchiole, they themselves do have certain alveolus. Now, that is the exact difference, doctors. Certain lung segments do have tertiary bronchiole without any alveolus on their wall, tertiary bronchiole branching out into alveolar duct that ends up into alveolar sac, right. Whereas, certain lung units will have the tertiary bronchiole with alveolus on their wall, and those airways, those tertiary bronchiole which consist of an alveolus on their wall are called as respiratory bronchioles. Okay, no confusion here. Fine. Now, we do have respiratory bronchioles which consist of alveolus. Now, doctors, if you look at all these airways, okay, now starting from trachea all the way to main stem or principal bronchi, which divides into segmental and lobar bronchi, which again dividing into primary, secondary and tertiary bronchioles. All these structures from trachea all the way to tertiary bronchiole, all these structures do not have any attachment to alveoli. From the trachea onwards till tertiary bronchiole, these airways, they do not have any connection to a live alveolus. Okay, they do not have any connection to an alveolus. Because they are not connected to an alveolus, these airways, because they are not connected to alveolus, these airways do not participate in gas exchange. You know very well, gas exchange is taking place only in an alveolus. Because these airways are not connecting to these airways are not getting connected to an alveoli, these airways do not participate in gas exchange, doctors. Okay. Just because these airways starting from trachea all the way to tertiary bronchiole, as these airways are not straight away involved in gas exchange, we call these airways, doctors, we call these airways as a simple conducting zone. And this conducting zone is also called as dead space. Now remember, because these airways are not involved in gas exchange, as they are not participating in gas exchange, they are called as conducting zone, colloquially called as conducting zone, and the exact terminology is dead space, doctors. So what is dead space? Any structure in lung which is not involving in gas exchange is called as dead space. Hope you know that. Okay, fine. This is how the conducting zone is present. When it comes to respiratory bronchiole onwards, if at all it is present, and we do have alveolar duct and alveolar sacs which consist of alveolus. These three structures, my dear friends, is called as respiratory zone. Respiratory zone, also called as alveolar spaces. So on one side we do have dead space, on the other side just below the dead space we do have alveolar space from where there is actual gas exchange taking place and actual respiration takes place, doctors. So this is how the airways are divided into two broad divisions. One is dead space and the second one is alveolar space. Dead space is also called as conducting space, alveolar space is also called as respiratory zone. Okay, and needless to say, trachea and bronchi are cartilaginous airways, while bronchioles, primary, secondary, tertiary, as well as respiratory, alveolar duct and alveolar sacs, all these structures, okay, from primary bronchiole onwards all the way to alveolus, these airways are non-cartilaginous airways. Right. Now, what is the point you got to be familiar with a non-cartilaginous airways? Remember friends, non-cartilaginous airways are susceptible to collapse. or they are very susceptible to collapse. What is going to keep these airways inflated? What is going to keep the airway open and patent? They remain open only when there is air inside. Without presence of air inside the airways are not going to open, they shut close. Okay. Now, this is one very important point you got to be bearing up in your mind. Non-cartilaginous airways are always susceptible to collapse and they will remain open only when there is air inside those airways, which is why nature has designed a very fantastic mechanism that when you breathe out, just to make sure your lungs are always remaining open, there is always some amount of air in the respiratory tract. We call that air as residual volume. So, you cannot able to empty your lungs completely out, because if you let your lung completely dry out, you will have all the alveolus to go for collapse. All the alveolar duct will get collapsed. All the respiratory bronchiole, tertiary, secondary and primary bronchiole will get collapsed because they are not supported by cartilages. To make sure these airways remain open, lungs do have certain amount of air always present inside, and that is called as residual volume. We will come to know more about that when we take up lung volumes, doctors. Okay. So, this point you got to be very familiar here. You do have cartilaginous airways, non-cartilaginous airways, dead space and alveolar space. Now, measurements. When it comes to alveolar space, okay, alveolar space, doctors, on a normal tidal breathing, you know normal tidal volume is 500 ml. Out of this 500 ml, about 350 ml goes to alveolar space and dead space is going to receive just 150 ml. Okay. So, out of 500 ml, 350 ml goes to alveolar space and just 150 ml gets restricted in dead space. Now, friends, when it comes to dead space, we do have three different way of approaching a dead space. Okay. Please do not get confused in the terminologies, it is just the word, but most of the time the meanings are same. I will explain that now. Now, dead space can be named as anatomical, number 2 alveolar, number 3 physiological. Fine, we have anatomical dead space, alveolar dead space and physiological dead space. Do not think anatomical dead space is separate, alveolar dead space is separate, physiological dead space is separate, not like that. I will tell you now. Now, when it comes to anatomical dead space, my dear friends, it involves the conductive zone, that is all. Conductive zone which are anatomically not involved in respiration or gas exchange. Fine, doctors. Anatomical dead space is something which is inevitably not able to do any gas exchange, because they are designed just to conduct gases from the upper airways or from the upper respiratory passages like nose, mouth, pharynx, hypopharynx, larynx, right, and trachea. The airways are designed to simply conduct the air from these upper respiratory passages to the actual alveolar space, which consists of respiratory bronchiole, alveolar duct, alveolar sacs and alveolus. Since anatomical dead space, since these regions are anatomically designed in such a way to not to involve in gas exchange, we call that regions. Okay, starting from, even you can include your nasal passages, okay, starting from nose all the way to terminal bronchiole, since they are not involved in gas exchange. Okay, starting from nose all the way to terminal bronchiole. Doctors, I will give you a point of warning here. Now, many of your textbooks speaks about dead spaces in terms of upper airways, trachea, bronchi, they are all the dead spaces. Not just that, respiratory passages involved in breathing where there is no gas exchange taking place are also called as dead space. Okay. Now, this is one very important point which you might not be encountered in your regular undergraduate textbooks, okay, which is why I am emphasizing this. Please understand, dead space does not mean it is present only in the lung parenchyma. Okay. It is also present in your pharynx, it is also present in your nasal passages. Okay. So, the regions where air moves and that air is not taken up for gas exchange, those regions are called as anatomical dead space. When it comes to alveolar dead space, now please understand this. Alveolus is designed, the natural design is to the natural design is to involve in gas exchange. Okay, it is designed to involve in gas exchange. So, anatomically they are not designed to just conduct, anatomically they are designed to exchange gases, but in normal lungs there is not going to be any problem. In normal lungs, please understand this, in normal lung every single alveolus is going to involve in gas exchange. So, in normal lung, since the lungs is normal, alveoli are normal and these normal alveoli will be participating in gas exchange, the space we call as alveolar dead space is 0 or there is nil alveolar dead space. Okay. Now, when there is a condition with some disorders, if the alveoli does not able to participate in gas exchange, okay, in disease states, when the alveoli is not able to participate in gas exchange, those alveoli which are not involved in gas exchange, the volume of those alveoli are called as alveolar dead space. Okay. Now, remember, alveolar dead space does not exist in normal lung. Alveolar dead space does not exist in normal lung. It will be seen only in a disease state. Okay. So, only in a disease state certain alveolus do not involve in gas exchange and those alveoli are called as dead spaces, doctors. Now, what is gas exchange? You should be very clear in this understanding. Now, coming to gas exchange, let us take up a alveolus here. Every single alveolus is perfused by pulmonary capillaries. So, now we have an alveoli, we have a pulmonary capillary perfusing an alveoli. The purpose of pulmonary capillary circulation to an alveoli is not giving oxygen or nutrition to the cells, it is to extract oxygen from alveoli. Okay. So, you have a separate bronchial circulation and a separate pulmonary circulation. Bronchial circulation nourishes the lung, pulmonary circulation extracts oxygen and contributes carbon dioxide to the alveolar spaces. Now, when you consider gas exchange, my dear friends, please understand oxygen has to be moved out of the alveoli into the pulmonary capillary. At the same time, carbon dioxide has to be moved out of the pulmonary capillary into the alveoli. Okay. So, it is going to be an exchange, dual exchange of gases. On one side, lung should empty out oxygen, on the other side pulmonary capillary should empty out carbon dioxide. This simultaneous cross movement of gases is called as gas exchange. Okay. Now, when you call something as alveolar dead space, doctors, please understand this. Let me take up an alveolus, and this alveolus do have a capillary perfusion here. Now, when an alveolus is not going to be involved in gas exchange, now this is very important, be very clear in this concept. I will give you two examples, my dear friends. In example number 1, I do have a blockage of alveolus. Okay. Here in example number 1, I have a block in alveolus. In example number 2, the alveolus is functioning well, whereas the pulmonary capillary is being blocked. Blocked pulmonary capillary. Okay. Two different conditions with two different manifestations. Let us take up example number 1, that is blocked alveolus. In a blocked alveolus, you do not have air entry at all. The alveolus is not going to get any air, doctors. As the alveolus is not even ventilated, as there is no gas available in an alveolus, the alveolus does not remain open. You know that, right? Alveoli are non-cartilaginous structure, a non-cartilaginous structure will stay open only when there is air in it. When there is no air inside an alveolus, the alveolus cannot able to remain open. When alveolus does not remain open, the alveolus will go for atelectasis and it will be collapsed like this. There is going to be an alveolar collapse, which means it is an atelectasis. Okay. When it is an atelectatic state, you can't even call that as an alveolus, right. Now, when there is not even an alveolus, you can't involve that alveolus in calculating a dead space. Okay. So, it is not going to be an alveolar dead space, my dear friends, because there is no alveolus at all. Alveolus has been collapsed and the space has been taken off. It is just like taking an alveolus out of a lung. You are not going to include the thrown out grape into the bunch, isn't it? This is exactly what happens with obstruction of an alveolus. When there is no air entry inside an alveolus, the alveolus does not remain open, it will get collapsed. A collapsed alveoli and atelectatic alveoli will not be considered in calculating the alveolar dead spaces. So, what is this condition called as? Now, in case of blocked alveolus, the blood that is flowing into pulmonary capillary is not going to receive oxygen. At the same time, it is not going to liberate carbon dioxide. So, there is no oxygen entry, there is no carbon dioxide exit. There is no oxygen entry, there is no carbon dioxide exit, which means the blood in the pulmonary capillary that is supposed to get oxygenated is not receiving enough oxygen. Now, what does this tell you, doctors? The venous blood entering into that particular alveoli which is supposed to get oxygenated is not receiving oxygen. So, it leaves the alveoli without receiving oxygen as just the very same venous blood. While every single alveoli are functioning well and contributing oxygen to the pulmonary capillary blood, this one blocked alveolus alone is not going to contribute oxygen to the pulmonary capillary. This makes the blood to remain venous. When this venous blood gets admixed with normal oxygenated blood from other capillary, we call this admixture. There is going to be an admixture of venous blood from blocked capillaries, from blocked alveolus. We have admixture of venous blood from blocked alveolus plus oxygenated blood. Oxygenated blood from normal alveolus. So, when you have admixture of venous blood and oxygenated blood, what do you call this, doctors? This condition is called as shunting. So, admixture of venous and oxygenated blood is called as shunting. Since this shunt happened because of a block in alveolus and atelectasis, we call this shunt as intrapulmonary shunt. We call this shunt as intrapulmonary shunt, doctors. Now, I want you to be very clear with the word as well as the concept behind this word, because at the end of basic respiratory physiology, we will be taking up clinical respiratory physiology with one very important condition called as acute respiratory failure, okay, which is very important in terms of both clinical practice as well as your PG entrance exams. Okay. When we are going to study acute respiratory failure, I will be emphasizing these points there, doctors. As of now, just get this point as a primer teaser for the concepts that are going to come in a later point. Remember, because of admixture of venous blood from blocked alveoli with the normal blood from a ventilated alveoli, we call this as intrapulmonary shunt. Okay. So, this is intrapulmonary shunt and this is not a dead space. On the other side, when the pulmonary capillary is blocked, when there is a block in pulmonary capillary, you do have entry of oxygen into the alveolus. And this alveolus is going to remain open because air is entering, isn't it? There is going to be a normal air entry. Because air entry is normal, the alveolus will remain open. Now, these 2 points are very important, my dear friends. Please be clear here. You do have a normal air entry, you do have an open alveolus. Now, because the grape is still attached to the bunch, right, we can use this as to calculate the numbers. Okay. So, it is an open alveolus, there is a well good air entry inside this alveolus, but air that is entered into the alveolus is not getting utilized for gas exchange, because there is no blood flow in the pulmonary capillary at all. When there is no blood flow in pulmonary capillary, the air that has entered the alveolus will not be utilized for gas exchange. Now, my dear friends, this alveolus is going to contribute to a space called as alveolar dead space. Okay. So, alveolar dead space is nothing but an alveolus which should remain open, an alveolus which should receive ventilation, but the ventilated gases will not be involved in gas exchange across the capillary. Now, this space is called as alveolar dead space, my dear friends. I hope you are familiar now with the anatomical dead space and alveolar dead space. Now, since there is not going to be any significant condition, see, when can you expect a pulmonary capillary blockage? During conditions like pulmonary thromboembolism. This is another medical emergency. Okay. During pulmonary thromboembolism, you might experience certain blockage in pulmonary capillary which will lead to alveolar dead spaces. Now, you know very well, on a normal healthy subject, there is no way that the subject will develop pulmonary thromboembolism. So, there is not going to be any alveolar dead space. Now, remember my dear friends, alveolar dead space is 0. There will not be any alveolar dead space in a normal healthy subject. Only with blockage of pulmonary capillary, or when there is no blood flow at all. For example, there is going to be a very severe right heart failure. Right ventricle is not contracting. Without the right ventricular contraction, blood does not enter into pulmonary artery. Without blood entering pulmonary artery, pulmonary capillary perfusion is going to be inadequate. So, conditions like this, pulmonary thromboembolism, severe extreme right ventricular failure, these are the conditions that leads to formation of alveolar dead space, doctors, right. So, you know now what is an anatomical dead space, what is an alveolar dead space. Now, if you add anatomical dead space plus alveolar dead space, which means if you add the volume of airways which are normally present, normally not involving in gas exchange, plus the alveolar regions which are normally present, normally ventilated, but pathologically not involving in gas exchange, we call the net volume as physiological dead space. Okay. Now, because in a normal lung, alveolar dead space is 0, in a normal lung, my dear friends, anatomical dead space is equal to physiological dead space. You know the reason why? Because physiological dead space is equal to anatomical plus alveolar dead space. In a normal lung, alveolar dead space is 0. So, anatomical dead space plus 0 is physiological dead space in normal healthy lung. Only when there is pathology involvement, only when there is thromboembolism, capillary failure, cardiac output failure, in these conditions, there is going to be an addition of alveolar dead space. Together they contribute to physiological dead space, doctors. Now, these are the dead spaces and the mechanisms and the basics behind dead spaces. Now, let us come to the entrance points here. See, these dead spaces has to be measured, isn't it? Now, the point is, you cannot able to measure one alveoli, you cannot able to measure two alveoli which are becoming dysfunctional. Say for example, out of millions of alveoli, let us consider only 1 or 2 alveoli is suffering from thromboembolism. Now, out of million alveoli, everything is functioning normal except 2 fellows who are now to be called as alveolar dead space. Now, how are you going to measure 1 alveoli size and 2 alveoli size? So, we have devised a very different strategy, right. Let us not get into the details of strategies because they are not essential for PG entrance exams, those intrinsic nuances. But if anyone needs that, just ping me, I will explain in our Telegram group or Facebook group, my dear friends. Okay. So, you do have 2 kinds of dead spaces that can be calculated. Number 1, anatomical dead space that can be measured. by a method called as Fowler's method, also called as nitrogen washout method. Okay, anatomical dead space is measured by Fowler's method that uses a gas nitrogen. On the other hand, if we take up physiological dead space, as I just told you, we cannot able to measure alveolar dead space independently. So, measuring physiological dead space by a method called as Bohr's method, also called as carbon dioxide washout method. This is Bohr's method of estimating physiological dead space using the gas carbon dioxide. If you could able to estimate physiological dead space, that is by Bohr's method, you get physiological dead space, and you subtract that from anatomical dead space measured by Fowler's method, we will be getting what is called as alveolar dead space. Okay, doctors. So, these are the importance of dead spaces, shunting, the techniques with which dead spaces are measured, right. You should be familiar with a dead space, you should be familiar with the shunt, you should be familiar with the methods of estimating these dead spaces, doctors. Okay. So, this is how the architecture of lungs has been arranged and what is something called as dead space. In the next video, let us take up the terminal architecture, that is alveolar duct and alveolar sacs, and how they function. Okay, doctors. So, this completes the initial half of lung architecture. Thank you.